Hello, this is Rebecca Hergert. Today we're going to talk about a topic that only nurses truly enjoy and people that have health problems. We're going to talk about bowel elimination. The objectives that we're going to have are to assess the factors that are involved in healthy defecation, determine desired elimination patterns, discover interventions to facilitate healthy defecation, and identifies factors which diminish the ability to defecate properly. Terminology. Okay, you've already come up with one, defecation. That means to move your bowels, to poop. Feces, another word for this form, poop. Occult means hidden. Valsalva maneuver is a bearing down. Take a deep breath, bear down. A vagus nerve is a nerve that's stimulated whenever you defecate that can cause your heart rate and your blood pressure to drop, and that's called a vagal response. And oliguria is just a decreased amount of urine. And I'm not 100% sure why I put that in the defecation, but it's there, so that's what it is. Basics, bowel patterns vary between individuals. It depends on what you're eating, what you're drinking, if you have any disease processes that affect it. Illnesses or change of circumstances can change your bowel patterns. If you normally drink a lot and then you're in a situation where fluid's not as available, your stool usually harden up. Problems including diarrhea, constipation, impaction, and obstruction can occur. Sometimes if you get a very thin, watery diarrhea, it may not be that your bowels are too loose. It may be that you have a solid mass, which would be an impaction up above. The obstruction just means that it's blocked up. It's not going anywhere. And constipation means that your stool's harder. There's less fluid in it, so they're really hard to move. Typical interventions include your diet. You want to increase your fluid, your water, and you want to increase your fiber. Activity. If someone's bowels aren't moving well and you can get them up and moving, get them walking, that increases peristalsis, and it can help them to get their bowels moving again. That's a frequent thing that we need to do after surgery, is to get patients up and walking within the next day or two, depending upon what kind of surgery it was, so that they do not have the problem of constipation or impaction. We can also give some medications. We have stool softeners and we have laxatives. Stool softeners just do that. They soften it up. Laxative causes you to defecate. Enemas, that's a more mechanical means. Now you're going to loosen things up and lubricate things up with, you can be oil, it can be soap suds, it can be tap water. We're going to talk about the different kind of enemas toward the end of this. And digital disimpaction is just when you lube up your finger, a digit, and go in and kind of break things up and help it move out a little bit. Stool is evaluated using the Bristol chart, and I do have that Bristol stool chart up in Moodle for you to see. Okay, diarrhea is a symptom. It's not a disease. Its definition is frequent, thick to thin liquid stool. It can be a side effect of medications. A lot of antibiotics have a side effect of diarrhea. Tube feedings have a side effect of diarrhea. It can be a bacterial or a viral invasion of the digestive tract. It can be a response to your diet. My mom used to tell me that if she ate graham crackers, it would help keep her bowels loosened up. She would be able to go better. It can be due to increased motility of the bowel. Sometimes whenever someone's really nervous, they'll have diarrhea just because of the increased peristalsis. Or it could be, as I said, liquid oozing around an impaction. So you need to find out if they're having diarrhea, why. Before you start wanting to prescribe Imodium to stop the diarrhea, you really need to find out why they're having it. Constipation is also a symptom and not a disease. Constipation is infrequent bowel movements, difficulty evacuating the bowels, inability to defecate due to hard stool, hard feces. A lot of times, constipation in a post-op patient is because of pain meds. Pain meds tend to slow down your motility of your gut, slows down the peristalsis of your intestines. Therefore, more water is absorbed. Therefore, the stool gets much harder to pass. Change in fluid or diet intake, aging process. As you get older, your peristalsis slows. A lot of elderly people, bowels are a big topic, and that's because they're problematic, because their peristalsis is slowed down. Ignoring the urge. I had a nephew that used to not like to stop to go move his bowels. So he would just wait. And then we got to the point where you had to wind up giving him enemas and disimpact and everything else. It was just like, stop, go poo, and come back, it'd be okay. And laxative misuse. If you use laxatives too much, they kind of stop working and make it to where you have to have them in order to use them, so you have to keep increasing your laxative use. A vagal response is a drop in blood pressure and bradycardia, and it's just a slowing down. Brady means slow, bradycardia means slowing of the heart rate, and it can be caused by straining to defecate. Common findings: in people who have constipation, you often find hemorrhoids, which are just big veins right at the rectal area. They're loose, a lot of times flabby. They will sometimes bleed when patients wipe. They're actually varicose veins down around the anus. They can be, just like any other blood vessel, they can get occluded. They can get clogged up. So if you have stool that's pressing above those veins for very long, you can wind up with blood clots down there. They can get inflamed. They can get really sore. That's why they have things like Tux and Anusol to kind of decrease that swelling. They itch. They can be internal or external. You can see external. You can only feel internal. And it's talking about the rectum itself. Sometimes you can just spread a cheek and look, and you see external hemorrhoids. Sometimes whenever an internist or a GI doc checks them, they'll find it on the inside. It can be due to chronic constipation. Pregnant women often have hemorrhoids. People who are obese have hemorrhoids sometimes. Chronic liver disease, because the blood flow can't go the way it needs to, it kind of gets, it becomes, has stasis. It slows down and it just pools. And that's one of the places where it pools. And a low fiber diet will also cause constipation, and therefore it'll cause hemorrhoids. Guaiac stools are a test that they do to check if there's any blood in the stools. It checks for occult bleeding. And all you do is take a stool from 2 different places from the sample, and it comes a little card, and there's 2 little windows in the card. You put one, take stool from one area, put it on one side of the card, stool from another area, put it on the other. Close the card, you put a couple drops of a reagent, and if it turns blue, they've got blood in their stool. However, if they have a lot of iron in their diet, it will also show like they have blood in their stool. If they have a lot of meat in their diet, if they're taking iron, those will all show false positives. Okay, the Valsalva maneuver is when the patient forcibly exhales against closed nose and mouth while bearing down as if they're having a bowel movement. That's classic Valsalva maneuver. Anybody that's ever been constipated has done it instinctively. An impaction is when it's impossible to pass the stool. It's stuck. It's not going to go. It occurs with a history of constipation. That's why you have to be careful. In a nursing home, usually if a patient hasn't passed stool in 3 days, they start making sure that they give them something, sometimes even 2. In the hospital, if your patient has not moved their bowels 2 to 3 days, you better be finding out what their normal pattern is, better be seeing what medicines are on, and you might want to let the physician know, because they're either going to need a stool softener, laxative, maybe even an enema, depending upon how bad things are. So to the lay person, keeping track of bowels movements are not really an extremely interesting topic, but for nurses, it tells us a lot about what's going on in their GI system. You really have to be on top of that and know when they moved their bowels last. Symptoms of impaction are constipation, rectal discomfort, anorexia, nausea, vomiting. Your body is always making gastric secretions, so if they can't go forward, they're going to go backwards. You're going to throw up. They'll have abdominal pain. They may have that thin, watery diarrhea, just small amounts all the time, constant oozing. Urinary frequency, it's pressing against the bladder. The stomach will distend. Prevention is key. You really have to know when patients have moved their bowels and be on top of that, especially if they're on any pain medications or if they're on any medicines that tend to slow down their peristalsis. Be always aware with it with elderly people. The vagus nerve, when it's stimulated, the heart slows down. They can have autonomic dysreflexia, and you see this a lot in patients who are quadriplegics. For no reason whatsoever, their heart rate drops, their blood pressure drops. You're starting to look at their meds. Are they on any blood pressure medicines? Did we give them something? No, it could be very likely that they've got an impaction or that they're constipated. You need to help them get their bowels moved. With spinal cord patients, sometimes their blood pressure will go really, really high, and their heart rate will drop. So you kind of have to watch. They may very well have an impaction. All right, that's good for our assessments. We'll be back in a little bit to talk about what we're going to do about that, our interventions.